So we're a bit faster, but also be careful. And whenever we find out that there is something to discuss more, we stop and discuss. Okay. All right. Once again, good evening to you all. Our topic of discussion today will start with typhoid fever. This is a very important endemic disease in low economic settings like our country. I want to lay foundation that many people that are diagnosed with typhoid fever, they don't actually have typhoid fever, because the method we use for diagnosis is not is a controversial method. That is a Widal test. For us to diagnose accurately, we have to do some cultures, being it blood, urine, stool, or even bone marrow, as the case may be. And even if you are going to use Widal, it has to be a serial rise in a Widal titer that may suggest typhoid fever. You find out that many people come to the hospital with the Widal test to see a doctor, especially in the private setting. And if you did not accept the test, they will feel like you're not there to help them. Okay? So please, we should be advocate of educating this kind of patient. The reason being that if you are diagnosed with typhoid, you end up with an antibiotic. So it's one of the most common way that we abuse antibiotics through diagnosis of typhoid. Many patients will come and tell you their titer is 180, is 160, and they have started medication. So please, we should know how to counsel them that that test is not important. And many specialist hospitals are not writing those tests. But majority goes to private hospital or clinic or somewhere and be doing this kind of tests and judging. We find that somebody will be taking antibiotic for almost 2-3 months. You want to see until that salmonella titer is low, so please, we should wake up and be educating. Had it been the treatment for typhoid, it's not antibiotic, it's paracetamol. No problem, who cares? Because if you take paracetamol for those period of time, there is the resistance is not known to occur in those drugs. But antibiotic, anything that will make people to be using antibiotic incessantly and unnecessary, so we should educate the public about that, and if possible, stop. Okay, so without wasting much of time, we go for salmonella typhoid fever. Okay, is a major cause of illness in 19th century in Europe and USA. But infection is more common in low socioeconomic status because fecal-oral route is one of the major route of transmission. Usually in overcrowded areas and poor sanitary condition. Now, because of other advanced countries, they have better, they are not crowded like our country. They have better sanitary methods. So the disease is less common in their areas, okay? But now, mainly a disease of developing countries in Africa and Asia. So it's actually a disease seen in low socioeconomic status where there is full of overcrowding, poor water hygiene, poor sanitary system, and what have you. Okay, let's go to the next slide. So etiology. The cause of typhoid fever is by Salmonella, but this Salmonella, there are of different species. It was known to be an obligate human pathogen that occur in the digestive tract without showing any signs of disease. So it's actually an obligate organism that lives with us. Unless when there is break in immunity or some other factors set in, that's when it can cause asymptomatic disease. It's transmitted via human, etc. So meaning fecal-oral route is one of the ways of getting that. Meaning again, for us to eradicate this disease, we have to have a better system that handles our excreta. And that is why it's common in developing countries, okay? Next slide. So as we said, the agent is by Salmonella, okay? So this Salmonella is classified into, okay, is a gram-negative, yes, and it's facultative route, meaning it's a bacilli, okay? and it belongs to a group of family called Enterobacteriaceae family. There are lots of bacteria that belong to this E. coli and what have you. So previously known as 3 species, in existence before, it's known to be 3 species like Salmonella typhi, the one that causes typical of typhoid, Enteritidis, and some people even added paratyphi, which can cause some, then Salmonella choleraeus, okay? So now the nomenclature with 1 species and many serovars. So they now make it that it's just a 1 species, but they have a lot of different serovars, okay? So one of the serovar is typhi, Typhimurium on Enteritidis, okay? So it's just the same organism, but with different serovars. But before, it was thought to exist in 3 actual different forms, typhi, Enteritidis, and choleraeus. But recently, it was known that it's just Salmonella, but with different serovars. Could be typhi, one of the serovar, Typhimurium, or Enteritidis. Next slide. So it's serologically positive for liposuction. So it has also antigens, O9 and O12 antigens. It also has flagella antigen, okay? The polysaccharide capsule antigen V1, which is specific only for S. enteritica serotype typhi. We said it has antigens O9 and O12. There is also another antigen, V1, but again, it has some flagellar antigen, meaning it has, again, for the V1, it's specific for Enteritica and typhi. We said it's just the same Salmonella, but it has serovars. One of the serovar is Enteritica, Typhimurium, or typhi. So this V1 polysaccharide is specific for these 2 serovars. That means it's absent in Typhimurium. It's only seen in Enteritica and typhi. Next slide. So the bacteria need to survive gastric acid barrier to reach the small intestine. So any factor that causes acrohydria will lower the infective dose. Simply mean that the acid we have in the stomach, it poses some protection for us against Salmonella. For Salmonella to be able to invade our body, get into our systemic circulation, it has to pass through the stomach, and we know we have a lot of acid secretion in the stomach. So that acid, one of the function of it is prevent rapid proliferation of this organism. So in people that for one reason or the other, they don't have, or they have reduced acid in their stomach, so Salmonella will easily get into their system because the function of that acid in preventing the bacteria from getting into the systemic circulation is reduced because of the absence of that acid. So what are those kind of people? People that are prolonged, that are taking proton pump inhibitors for a very long time, their acid is suppressed, so the bacteria could easily get into there. People, for some reason or the other, there are people that have some surgeries for the stomach, where part of the stomach that produces hydrochloric acid is following surgery, they lost that part of the stomach, okay? So that means they don't have acid secretion. So those kind of organisms and patient, again, Salmonella could easily get into their system, okay? So this Salmonella gets into where it's finally, its destination is at the Peyer's patches. So it is then transported into the underlying lymphoid tissues from the lymphoid to reticuloendothelial system of the liver and spleen and get to the systemic circulation, okay? But in the intestine, at the Peyer's patches is one of their final destination before getting to the lymph nodes and get to the circulation. Next slide. So the bacteria multiply and survive within the reticuloendothelial system, the spleen, the liver, and are released into the blood. Incubation period is usually 7 to 21 days, and the organism is widely disseminated in this bacteremic phase involving the liver, spleen, bone, gallbladder, PS patches. Okay, so these are some of the organism is widely disseminated in this bacteremic phase involving these organs. Okay, so these are some of the commonest sites where this organism is being found. Next slide. What are the clinical manifestations? The commonest differential is malaria. Many patients that are diagnosed with typhoid fever, maybe 80%, they have actually malaria. So please, we should have low threshold of diagnosing this disease, especially in patients that use Widal test for the diagnosis, okay? It has to be a serial Widal, or the best thing is to do blood culture, urine culture, or stool culture, depending on the time of onset of the symptoms. Many people, if you start practice, they will come from private clinic, especially. They will come and tell you they'll be calling, I have typhoid. I take antibiotic 10 days. It's still 160. I don't know. So please, it's not the test that it's the clinical features. Again, they are abusing antibiotic, and antibiotic resistance is becoming very serious issue nowadays. So it poses a great danger to the society. As I said, had it been the treatment is anything that is no antibiotic, fine. One can take because you don't develop resistance for those drugs. But antibiotic risk of resistance is very high if you are taking them when there is no indication. Okay. So these are those some of the symptoms. If you look, they could mimic so many diseases: fever. They may have paradoxical bradycardia, headache, abdominal discomfort, constipation or diarrhea. They could have jaundice, vomiting. They could have anything. Sometimes they present with symptoms of complication like osteomyelitis. They can have GI perforation, so they could present with peritonitis. They could have, they could even come with some psychotic symptoms because they could also affect the central nervous system. So, but again, if you see somebody with fever and you check the pulse rate is low, one of the commonest cause of tachycardia is fever. Fever is #1 cause of tachycardia. But you have somebody with fever and that fever is high grade, maybe step ladder pattern even, and someone is having bradycardia. So you start to think of salmonella because ideally fever should cause tachycardia. So who can tell us the relationship between fever and bradycardia? What is that called? Briefly, we have 3 lectures to do today. Anybody? It could be an exam question. Please, can somebody cooperate, please, so that we move on? Hello? Okay, if you have fever and bradycardia, it's a sign called Faget sign, F-A-G-E-T. Salmonella is not the only cause of Faget sign, but is #1 in the list. There are like 20 causes of Faget sign. Presence of fever, then patient is having bradycardia. Salmonella is #1. There are other ones. You don't want me to ask you. That's why maybe I will just mention 2, 3 and go. But you have to know. It could be an example. The following can cause Faget sign. 1, salmonella, yes. Yellow fever, leptospirosis, okay? So yellow fever is the second commonest cause of Faget sign. Leptospirosis, brucellosis, okay. Those kind of infection, they can come with fever and bradycardia as against tachycardia. Next slide. So again, they could, liver, spleen can be affected. They could develop hematomegaly. They can go to the spleen, and they can also affect the meninges. Patient presenting with features of meningitis, psychosis, and what. They could also cause intestinal obstruction and perforation. Next slide. Osteomyelitis, there are a lot of complications. GI perforation, cholecystitis, shock, DIC. But yesterday we said malaria is one of the commonest causes of DIC in this environment. So these are some of the complications: GI perforation, hemorrhage, and what have. Okay, myocarditis, shock. Next slide. So, what are differential? Anything that causes fever, feeling of unwell can cause that. Malaria is #1, but you can look at long list here. So everything that can cause fever, malaise, diarrhea, constipation can cause that. Next slide, please. So this is a temperature pattern. It's typically step ladder in typhoid fever. We should know other pattern of fevers in other disease. Pell-Epstein fever. We should know what a Pell-Epstein fever is. I believe some of us know about that. We should know what Charcot fever. We should know what remittent fever. So just know two causes: remittent fever, Charcot fever, Pell-Epstein fever. Where do we see Pell-Epstein fever? Who can tell us? So Pell-Epstein fever is a fever that persisted for 7 days. Then there is it subsided for 7 days. It's also come back and lasts for another 7 days. That's Pell-Epstein. It's typically seen in patients with lymphoma. All right, next slide. Diagnosis. For us to diagnose salmonella typhoid, we have to do culture, as I said, to detect the organism, not the antibody that we use for viral, okay? So if it's first week of symptoms, you do blood culture. If it's second week of culture, you do stool culture. If it's third week, you do urine culture. However, any available culture at any time has the potential to culture the organism, okay? You can see the blood culture, if you done first week of the disease, almost 40 to 80% sensitive. Again, sometimes we do bone marrow, but especially if somebody has been taking antibiotics, maybe for 1 week, 10 days, doing culture may give a negative result because of prior use of antibiotic for that particular long period of time. So in that case, we advocated to do bone marrow culture. Bone marrow culture, even in the even after commencement of antibiotic, can give 80 to 90%. So these are the things we should be doing if we really want to diagnose typhoid, not the wider. Okay, next slide. So this wider type is controversial. And many people will start disturbing you. Doctor, I have 180, I have 160, I have 80, So it's telling him it's not the test, it's the human being that you test. Please. This is one of the things, because the treatment is antibiotic. You want to be objective in using antibiotic. It has to be judicial, you understand? You have to have objective evidence of doing that, because continued use of incessant antibiotic without proper indication is what culminated to the resistance pattern we have in this part of the country, okay? So, and the wider test, it detects antibodies, and these antibodies can last for a year. Who knows whether the typhoid I have 1 year is the antibiotic that you are detecting now. So that's why it's not. It's just the presence of antibodies, and this antibody can last for years in the body. Okay, it does not mean the present antibodies. The antibodies could be produced several years, months. So that's why it's not good to do that. Okay, next slide. But if you have somebody with disease, if you do it serially, you do it today, tomorrow, you see the rising titer, the titer is rising. It could suggest active disease at that time, okay? So these are some of the diagnoses. Leukopenia is common. Again, we used to know that following bacterial infection, WBC rises, okay? So elevated WBC is seen in bacteria. There are exceptions. Exception is Salmonella. Salmonella, typically, they have low WBC, typically, okay? Again, viral infection causes rise in lymphocyte count. But again, there are some bacteria that causes rise in lymphocyte count. So the typical feature you see in Salmonella is lymphocytosis with leukopenia. Likewise, in TB will also cause lymphocytosis, despite Mycobacterium being a bacteria, okay? So some few bacterial infections, not necessarily viruses, can cause lymphocytosis. And again, some few bacterial infections, they cause leukopenia as against leukocytosis for bacteria. If you give you a scenario, there is a leukopenia, is a bacterial infection, you start to think of that. All right. Okay, next slides. Please excuse me for just 2 minutes, please. I'm sorry, just 2 minutes. I'll be back. 2 minutes, please. All right. Sorry. So, rapid diagnosis and institution of appropriate antibiotic treatment is very important. Adequate bed rest, hydration, and correction of electrolyte, antipyretic therapy, adequate nutrition, soft, regular follow-up and monitoring. So these are kind of, if you diagnose patient with typhoid fever, you have to start prompt antibiotic, but you have to make sure you really have high index of substitution for that. Because if you delay antibiotic, again, complication concerning like perforation, like meningitis symptoms like intestinal obstruction, and what have you. So prompt start of use of antibiotic is very important, okay? And again, adequate bed rest, rehydration is very also important. The drug of choice now is usually quinolones. So if somebody can take orally, you can give it for 5 to 7 days. However, for very severe disease, you give it IV. But you have other options apart from quinolones, like third generation cephalosporin, ceftriaxone, okay? Azithromycin, they're also very important. Before, chloramphenicol is one of the #1 drug, but because of so many problems of chloramphenicol, that's why it brought down in the list of the other. Other drugs that can be used are amoxicillin, Septrin, again. So in case of severe disease, you have to use intravenous drug for more than 5, 7 days, 10 days, depending on the response of the patient. And you watch out for the electrolyte. It's one of the diseases that patient comes with electrolyte derangement, severe form, indeed. This could be from the diarrhea, from other things that may lead to this electrolytemia. Next slide. So if somebody comes with severe typhoid, you need to resuscitate that patient because, again, risk of septicemia is very high. You have to resuscitate. Surgery If they develop internal obstruction or perforation, you may need to give additional antibiotic if they develop perforation or obstruction. Next slide. So some patients they have a carrier state. They become chronic carrier of salmonella. So for those excreting the S. typhi for more than 3 months after infection, they are called chronic carriers, and they have a problem. If they have gallstone, to eliminate the bacteria in them is very, very difficult, especially using antibiotics. Sometimes you have to remove the gallstone before you can treat them adequately. And again, you have to treat for 4 weeks using quinolones. Okay, so if they become chronic carrier, if they have a gallstone, treatment of elimination of the bacteria is difficult in them. We need to do cholecystectomy and remove the stone before you treat the patient adequately. Next slide. So how do you prevent? We said it's a fecal-oral thing, poor sanitary, poor good hygiene, poor waste disposal, poor refuse disposal, low quality water intake. So if we address those things, incidence of the disease will be very low. Then we have to use safe and efficient waste and sewage system. We have to avoid eating out of the house as much as possible. We have to enlighten the public about personal hygiene and environmental hygiene. We have to treat food vendors in how to handle food substance, okay? Because it's a very good source of food. Next slide. So there are vaccinations now available for typhoid fever. They are of different categories, but we should just know that there are a lot of there are some few types of, some are polysaccharides, some are of different variety, like type 2-1A is also available. I'm not sure whether V1 polysaccharide vaccine is available, but I'm sure of oral form type 2-1A. Okay, next slide. But for type 2-1A, you need to give booster doses after 5 years. Okay, so if there is any question, clarification, please, you can ask.
Hi, good evening, sir. I just have one question, really. I wanted to ask, which age group is most susceptible to typhoid?
Okay. Commonly, there is no particular age group. Commonly, there are susceptible to. Commonly, you understand? Not like malaria, where, however, for any disease, low immunity is a risk factor for almost every disease. Who are the people that have low immunity in terms of age? Younger age and extreme of age, right?
Oh, yes.
So, but there is no specific age to my knowledge. I don't know that these are the group of age where they have more risk of disease than the others. But as I said, generally, any infectious or most of the other disease, advanced age and low age, because of the immunity and some other factors, the disease tend to affect those age and tend to be severe in them.
Okay.
Yes.
Okay. Thank you.
All right.
I also found something in a book I was reading, something about rose spots.
Okay, rose spots, they are some of the manifestations of typhoid fever, especially if it becomes septicemic. You understand? Okay. You can see something like little hemorrhages, right?
Yes, yes.
You understand? So there are a lot of symptoms you can see. I said they can even develop osteomyelitis, So that one is usually seen if it's disseminated. You understand? Maybe so, because typhoid can easily become septic. So typhoid septicemia, okay? It's one of the cardinal signs that if you see rose spots, so likely it's not confined to one organ. It affects the system, okay?
Okay, so it's more of a complication than part of this. It's more of
That's
a
what I
complication.
said. If it becomes, normally typhoid should not come with features of septicemia.
Okay.
If one develops septicemia, meaning he has a complication of typhoid. And one of the presentation one may have is development of rot spots.
Okay, I can understand.
Bleeding, yeah.
Thank you.
No problem. Thank you very much. Let's go for urinary tract infection. We have 3 lectures to do today. Again, each slide is very important. We pay more attention to the most important slides. So urinary tract infection refers to an infection occurring anywhere along the urinary tract from the perinephric fascia to the rectal meatus. Urinary tract infection. It accounts for 1 to 2% of hospital visits, and complication can cause severe renal disease, including end-stage renal disease, gram-negative bacteria. So why do we need to treat urinary tract infection? Because even if it's lower urinary tract, it can ascend, affect kidney, pyelonephritis. It can even affect the coverings of the kidney. So, and if not treated, it could lead to acute renal failure. It could lead to chronic kidney disease. So if you look at, if you can grade urinary tract infection as cause of kidney disease, maybe you can give it around number 6. It's one of the common, but not too common, but it's one of the common causes. If you remove hypertension as a cause of chronic kidney disease, if you remove diabetes mellitus, if you remove obstructive uropathies, if you remove NSAIDs stroke traditional medication, if you remove glomerulonephritis as a cause of kidney disease, then the next thing is urinary tract infection. Chronic urinary tract infection, untreated, can lead to that. Next slide. So you can classify urinary tract infection based on so many: etiology, location, duration. Okay, next slide. Also based on complexity. It's better to discuss this complexity. Other ones are self-explanatory. So urinary tract infection could be complicated or uncomplicated. Why do we need to know it? Because in a patient with uncomplicated is just, okay, let's highlight features of complicated urinary tract infection. Complicated urinary tract infection is seen in a patient with one of the group. Okay. So people that have structural abnormalities of the urinary tract infection. So any structural abnormality in the presence of urinary tract infection, it becomes complicated. That's one group. Then any patient with features of urinary tract infection that has low immunity. Low immunity could be from retroviral disease, GM, could be chronic use of steroid, could be patient on long-term chemotherapy, could be patient with background malignancy, developing urinary tract infection. So that should be treated as complicated urinary tract infection. And any patient by which you culture an active organism in the urine, positive culture, that one should be treated as complicated urinary tract infection. Patient with sickle cell disease having a urinary tract infection is, again, if the urinary tract infection is bilateral, you understand, maybe somebody has pyelonephritis bilateral, that's also complicated urinary tract infection. Why do we need to segregate those kind of people? Because the treatment is intravenous antibiotic. Even if you are not going to admit the patient, it's better to give him IV antibiotic. But just for uncomplicated urinary tract, there are a lot of oral antibiotics that could suffice for just 5 days, 1 week or so. So that's just it. So you have to pay attention to, if you have a patient with urinary tract infection, look at whether he has one of those symptoms that make it to be complicated urinary tract infection. And a patient with also stone in the urinary, okay, any form of structural abnormality, stones, okay? So you have to give IV antibiotic for that patient. Next slide. So what are those risk factors? These are risk factors for urinary tract infection generally. Female, because they have short urethra, sexual intercourse, pregnancy, menopause, spermicide exposure, impaired host defense, like immunosuppressive patients, urinary tract obstruction, stones, instrumentation. Any patient that has instrumentation. Sometimes, if you give, you can even give antibiotic for somebody that does not have any sign of infection, but has urethral catheter in situ because it's a nidus for urinary tract infection. You understand? So it's not always that when you have catheter that you must give, but if somebody have other risk factors again, or you feel poor hygiene and some other things like that, it has high chance of developing urinary tract, you can give antibiotic for that. Next slide. Next slides. So these are the list of the organisms: E. coli, Staphylococcus saprophyticus, Proteus mirabilis, Klebsiella, Enterococcus, Pseudomonas. These are the commonest organisms. Okay, E. coli is the commonest cause of urinary tract infection. And who knows which other disease is E. coli is the commonest cause of about 70 to 95%? Who can tell me? I'll give 10,000 naira. I'm a bit faster today. I don't have much shirt, and you have to cover 3 topics, okay? So who can tell us another disease by which E. coli is the commonest, another infection is the commonest cause, and it's up to 70 to 95%. Okay, I added another 10,000, 20,000. Okay, let me answer myself. We don't have much time. People are shying of contributing. Traveler's diarrhea. The commonest cause of traveler's diarrhea by more than 70% is E. coli. Next slide. So again, sometimes urinary tract infection is symptomatic. Sometimes it's asymptomatic. Okay, symptomatic UTI occurs when there is a balance between the virulence and number of infecting organisms and host defense interrupted. Okay, infection is by 2 major routes. Commonly is ascending, plus bacterial colonization, distal urethra or vagina can enter and invade the proximal urethra and bladder. Okay, so ascending infection is one of the major sources. So that means genital hygiene is very important. Okay, next slide. It could be hematogenous, okay, from the blood, from one part of the system to urogenital system, okay? So again, it could be via lymphatics. It could be direct extension in patient with VVF, okay, because of the close proximity of VVF, of the deformity there, the urethra. But it could also occur from hematogenous routes. Somebody have maybe sepsis involving abdomen, can ultimately get into urinary system, to the brain, to the liver, and other parts of the body. Okay, next slide. So these are the clinical symptoms. They could present with asymptomatic, but for some reason, maybe from checkup, you check bacteria in the urine. There could be symptomatic acute urethritis or cystitis. It could be prostatitis. It could be pyelonephritis. They could come as part of the septicemic illness. Next slide. So usually could be abrupt onset of frequency and dysuria. Could be scalding pain felt in the urethra. That could be one of the symptoms. Could be systemic symptoms like, okay, sometimes systemic symptoms are there or absent. Urine may have unpleasant color. Sometimes it's just a change in color or odor of urine. Sometimes they can present with hematuria as the symptoms. Okay, all the symptoms, they can just pinpoint presence of urinary tract infection, even the blood in the urine in some cases. Next slide. Again, one of the common presentation is pyelonephritis, inflammation of the renal pelvis, okay? So this could present as acute or chronic. If you have combination of fever, loin pain, and tenderness with significant bacteria, implies infection in the kidney, which is an acute. If you do histology, you can see some focal infiltration of polymorphs. And if you can, one of the investigations, CT, can show which shape areas of inflammation, but commonly we use ultrasound. Ultrasound is enough to diagnose uncomplicated pyelonephritis. And the treatment is antibiotic. If it's bilateral, you have to give IV. If there are other signs of complicated UTI, you have to give IV again. But pyelonephritis should be well treated, because if not treated, it could become chronic and subsequently affect kidney. Next slide. Again, it could be inflammation of the bladder, okay, cystitis. This presents with suprapubic pain during or after voiding. There could be desire to void after bladder is empty due to spasm of the bladder wall. And treatment, you give antibiotic. One of the antibiotic used is trimethoprim 20 milligram BD for 5 days. But again, when ciprofloxacin and a lot of drug can be used for treatment of cystitis. Next slides. So diagnosis usually is clinical. However, you need to demonstrate presence of the organism in midstream urine or presence of neutrophils in urine. Okay, either you culture organism or you can detect presence of neutrophils in the urine. That plus the history that you have, that's the way it is diagnosed. Next slide. Okay. Hello. Investigation. We said you have to detect one of the diagnosis. You have to detect presence of the organism in midstream urine. So you get midstream urine. You send for microscopy. Then you could look for presence of proteinuria, leukocyte, nitrite, and RBCs. It's better to send the fresh urine for MCS. If you detect 10 to 5 colony forming units is diagnostic. So there is a way they analyze this urine sample, you understand. If you have more than 10 to 5 colony forming unit is diagnostic. If you have less than 10 and pyuria is still significant to think of urinary tract infection. But ultrasound is also very important, especially if it is pyelonephritis cystitis. Sometimes you can use intravenous urography, cystoscopy, you know. Next slides. So, what advice will you give a patient that is diagnosed with urinary tract infection? Fluid, intake of fluid. This will help to flush the urinary system, and you must give an antibiotic. And antibiotic depends on whether it's complicated or uncomplicated. We said in complicated, we give intravenous. In uncomplicated, if patient can tolerate orally, there's no vomiting, patient is not too sick, you can give him oral antibiotic. So the antibiotic depends on the common sensitivity pattern of the previous studies done in that particular region and awaiting the result of microscopic culture and sensitivity. Commonly, we start with ciprofloxacin in our center of floxacin. If the culture came out, if the cultured organism is not sensitive to cipro, we change to particular. Sometimes augmentin can also work for urinary tract. But before nitrofurantoin, when it's available, is also a very good. So, but commonly we start with quinolones. We change based on the culture. Usually culture comes after 24, 48, or 72 hours in some centers. Okay, but you have to know for uncomplicated, you have to give for a week or more. So treatment can be modified based on the culture and sensitivity, okay? Next slides. So sometimes again, UTI, urinary tract infection can be recurrent, okay? Meaning if it occurs more than once, then pre and post treatment urine culture are mandatory. So if somebody has urinary tract infection last 2 weeks, coming down with another thing, before you start antibiotic, you have to take culture. After the treatment, you have to also take culture to see whether, even if the culture is negative from beginning, you have to take after and compare. So recurrence of bacteria with same organism within 7 days of completion of antibacterial, implying failure to eradicate infection, usually in conditions such as, so if you have this presence of this, the UTI can be recurrent. Stones, scared kidney, polycystic kidney disease, okay? Next slide, please. So reinfection, when do we have reinfection? Means recurrence of bacteria with the same or different organism after 14 days of completion of treatment. It implies predisposition to periurethral colonization or poor bladder defenses. In this case, contraceptive practices should also be reviewed, okay? So if it's reinfection, it has to be after 14 days after treatment. And usually it's possibly from periurethral colonization or some poor bladder defenses, okay? Next slide. So we said part of the treatment, part of the advice, we should take a lot of water, almost 2 liters of fluid in a day. We should be voiding at 2 to 3 hours interval if possible. Again, we should void before bedtime and after intercourse. We should avoid any irritants spraying to our genitals. We also avoid constipation. So this is urinary tract infection. You have to have sometimes high index of suspicion for you to diagnose. As we said, somebody may just come with some form of little hematuria. So it could just be urinary tract infection. The major symptoms usually is dysuria, with or without fever, increased frequency, or change in color of urine, change in odor, or the urine is becoming very thick. So it could just be the sign of, symptoms of urinary tract infection. So sometimes you need a high index, but again, whenever you diagnose somebody with UTI, you have to also, okay, let me check whether, let me ask, let me examine whether this patient has other features that make this urinary tract infection complicated, so that I will give IV antibiotics. So I think we have come to the end of this UTI. Then we move to the systemic, rheumatoid arthritis. If you have any question, clarification, addition, you can ask. Please ask question. Your exam is around the corner. And most of us participated in the last exams that was done in Kano almost 4 years ago. So most of us, again, will also be participating in your exams. So please, this is a very good time for you to be reading adequately, practicing everything that you think will potentially come out in exams. Especially the examinations of various systems, communications, instruments that you think will also come out. So rheumatoid arthritis is also one of the systemic disease. It's not just a disease of the joint, it's a multi-systemic disease, okay? Yesterday we discussed about systemic lupus erythematosus being a multi-systemic. So likewise, rheumatoid arthritis again is one of the multi-systemic connective tissue disease. It's not only affecting the joints, it can affect the brain, it can affect the kidney, it can affect the lungs, it will also affect the blood, it affects various organs, it will affect the eye, the skin, okay? Next slides. Okay. Rheumatoid arthritis, again, has a criteria. The criteria that's commonly used, it was done in 2010, called EULAR criteria. And that criteria gives a guide on what 1, 2, 3 will you add for you to diagnose rheumatoid arthritis, okay? The criteria could be history of arthritis, and even the arthritis, which joint affected. Is it a bigger joint or smaller joints? Again, what are the other, okay, is it associated with rheumatoid factor positive or anti-citrullinated peptide antibody is positive? If it's whether they are absent, whether they are positive in minute amount, whether they are they are present, okay? Then other markers of reaction like ESR, C-reactive protein, and the duration of the illness. So these are the parameters used for the Euler criteria. Can we move to the next, please? Hello? Hello?
Hello, sir.
Yeah, can we share the screen? It's to 9 already. Okay. So you can see the pathology of rheumatoid arthritis. It affects synovial membrane, so causing synovitis. Then the fluid, it can affect virtually all the fluid, meaning in the joints, in the lungs, in the peritoneum. So they can have serositis, okay? Then again, they can have rheumatoid nodules. Then they can present with features of vasculitis. So these rheumatoid nodules are not too common, but again, in some few patients, you can see some swellings on the extensor surfaces. Then they can have serositis, as we said. And among the joint structures, synovial membrane is the commonest part of the joint affected, in which they cause synovitis, inflammation of synovial membrane. Next slide. You can see this is a structure of a joint. There is a bursa by the side. If it's inflamed, it causes bursitis. You can see some tendons along the joint, the synovium. The synovial membrane, as we said, is the commonest part of the joint affected, causing synovitis. Okay, this is a very good structure of a joint. It does not commonly affect the cartilage of the joint, but unlike osteoarthritis, okay, affect more of synovial membrane. Next slide. So what this synovial membrane, why do they have synovitis? Because there is infiltration with the lymphocyte and plasma cells and macrophages following the disease. Then synovial membrane hyperplasia and hypertrophy, then formation of inflammatory granulation tissue, what they call panus, then erosion. Again, it can cause erosion, not only of the synovial membrane, other joint structures. So, meaning rheumatoid arthritis is an erosive disease. Some joint diseases are non-erosive; they don't cause erosion. But rheumatoid arthritis is an erosive; it causes erosion. Okay, so this is one of the clear-cut difference between other joints, other joint disease. It is an actually erosive disease with affecting synovial membrane more than the other joints. Next slide. So this is also part of how, following the disease, how the joints are being affected. Okay, you can see synovial membrane being inflamed. You can see presence of these cells that were mentioned, lymphocyte macrophages infiltrating the synovial membrane, leading to formation of panus. Subsequently, it causes an erosion not only on the synovial membrane, but the other supporting structures, even the cartilage. But commonly, it may not just affect cartilage. Usually it starts with synovial membrane. Next slide. I think we have almost 40, so we have to be a bit faster. Next slide, please. We dwell more, time is not on our side, we dwell more. Okay, this one is very important. So we have joints, some markers of reaction like C-reactive protein duration, acute phase reactant duration, okay? So for the light joints, you can see affectation of the light joint is not important for diagnosis of, usually is the smaller joint. So rheumatoid arthritis affect more of smaller joint, unlike osteoarthritis that affect larger joint, okay? So you can see the mark for affectation of the smaller joint, there are more because they are more important in the diagnosis. If more of the large joint are affected, you think of other disease like osteoarthritis, okay? Maybe again, septic arthritis. Then the serology. If there is negative rheumatoid factor or ACP, anti-citrullinated peptide antibody, if it's absent, is 0. If it's low positive, 2. If it's high positive, is 3. So again, sometimes they might not be present, rheumatoid factor. And that's why they are called seronegative. Rheumatoid arthritis are divided into 2 based on this, either seronegative rheumatoid arthritis or seropositive rheumatoid arthritis. Though with negative rheumatoid factor and or anti-citrullinated peptide antibody, they are called seronegative. And those with positive, they are called seropositive. So you can see smaller joints are given more preference than the larger joint because the disease affects commonly the smaller joint. Okay, next slide. So the duration of the symptoms, synovitis, less than 6 weeks 0, more than 6 weeks 1. Acute phase reactant, C-reactive protein and ESR absent 0, present 1. Again, for you to definitively diagnose rheumatoid arthritis, you need to have a score of 6 and above. Okay? So 6 and above. Any score below that, it could be probable, it could be unlikely. So please, let's just read about this Euler criteria. Let's memorize it. It's very important. It could help us during our exams and practice. Next slide. So what are the pattern of presentation? They can present as acute, chronic, or there is particular presentation called palindromic. But commonly they present as a chronic disease. Commonly, maybe more than almost 80 to 90% they present as chronic disease. Next slide. So this is a graph showing clinical cause of RA. You can see there are 3, type 1, type 2, type 3. Please look at this very well. You can see it later. But I don't think nobody will ask you about that. Next slides. So what are those symptoms? I will keep on mentioning is a multisystemic disease. Apart from the joint affected symmetrical pattern, smaller joints, more of synovitis, and the joint usually associated with stiffness, especially in the morning. So if you have a patient with joint pain, swelling, with stiffness early in the morning, you have to bring rheumatoid arthritis as one of the most common things you should think of. Subsequently, they can lead to weakness, deformities, loss of function, fatigue, and other symptoms. Again, if they develop complication, they could come down with features of that complication. Lungs is one of the commonest system affected. They can affect lungs in more than 10, they can cause more than 10 different pathology in the chest. Okay, they can affect central, so they could come down with features of that system affected. Next slide. So what are those signs? If you examine the joint, there will be swelling. There could be joint tenderness. They could be, subsequently, if they could have wasting of the muscles around. Again, that joint may be deformed. They could have several deformities, which we shall see in our next slide. Okay, so swelling, tenderness, wasting of the muscles, and deformities. Next slide. So these are some of the things. If you alarm signs, if you have 3 swollen joints, especially the smaller joints of the hands, joints of the hands are small joints, okay? And I've forgotten to tell you that the commonest joint affected is metatarsophalangeal and metacarpophalangeal joint. Unlike gouty arthritis that affect first metatarsal joint, and unlike psoriatic arthritis that affects distal interphalangeal joint. So it depends on the joint. Usually, if you see metatarsophalangeal or metacarpophalangeal joint affected, it's most likely to be rheumatoid arthritis. If you do this squeeze test, look at how the hand is. You should squeeze this, okay? It's also one of the tests that you do. They may not be able to squeeze like this because of the deformity, especially for those with deformity. They could not squeeze as shown from the picture. They could not squeeze the other hand like that. Again, if the morning stiffness lasts for more than 30 minutes, it's also a very good marker of the disease. Next slide. Again, we said joints of the hand, so wrists commonly affected. In the wrist, they could have several deformities. They could have a swelling of the wrist joint, synovial membrane of the wrist joint. They could present with piano key sign. They could have tenosynovitis. I've never seen this piano key sign, but it's also one of the things that affected. They could have subluxation, especially of the ulnar side of the joint. So joint subluxation is very common. I think there are some pictures of subluxation. So wrist is one of the common joints because it's a smaller joint, again, affected. Ankle and wrist, okay? Next slide. So you can see they could affect flexor retinaculum. They could have peripheral nervous system and causes some features of peripheral neuropathy. And if they affect flexor retinaculum, they can develop a syndrome. Who can tell us what is that syndrome? Despite we're a bit faster, you have to tell us, please. It's very important for exams. If the rheumatoid arthritis,
Felty syndrome.
Felty, no, Felty has to do with, I will not tell you Felty, but it's not Felty. Felty has to do with splenomegaly.
Is it carpal tunnel?
Neutropenia, yes, carpal tunnel. Carpal tunnel syndrome. So there are five common causes of carpal tunnel. Who can tell us 2, 3? This one for MCQ. The following are causes of carpal tunnel syndrome, except, you know, the exam is going to be conducted in Kano, and we are part of the exam team. As we did the other time 4 years ago. So carpal tunnel syndrome, what are the causes of carpal? The following is an MCQ because the following are causes of carpal tunnel syndrome, except, please, it's past 9. Who can tell us faster, please?
Pregnancy.
Good. Pregnancy. That's
alcohol.
number 5.
Oh, that's number 5.
I'm not sure, but pregnancy is number 5 in the list.
Okay. What about alcohol?
I don't know. I don't think from all the sources I know before, there is no alcohol. But I don't know. You know, knowledge is vast, but I don't know of alcohol actually.
Okay. I wasn't really sure about alcohol. Okay. What else? Arthritis.
Okay, let me help you. You tried. Pregnancy is number 5. Number 1 is rheumatoid arthritis. Number 2, hypothyroidism. Number 3, acromegaly. Number 4, pregnancy is number 4, number 5. I've forgotten one. So we said acromegaly, rheumatoid arthritis, number 1, hypothyroidism, number 2, acromegaly, number 3. I'm not sure of Cushing's syndrome. You understand? Yeah, it's a cause. Then pregnancy, number 5. So these are commonest causes. If you see in MCQs, yes, you take them for yes, okay? Next slide. Next slide. So the hands, they could have different deformities in the hand. They could affect, we said, metacarpophalangeal, sometimes proximal interphalangeal, but rarely distal interphalangeal. Distal interphalangeal joint is affected commonly by psoriatic arthritis. But metacarpophalangeal, metatarsophalangeal is more in rheumatoid arthritis. Occasionally, they can affect PIP. Deformities, yes, they can have several deformities. The commonest one that we know is Schwann neck, but they could also have Botonius deformity and Z-shaped deformity. They could have subluxation of metacarpophalangeal, especially the ulnar side of the joint. They could have tenosynovitis. They could have a lot of deformities. Okay, next slide. So meaning if you have patient with rheumatoid, you have to examine the hand. You can see some of those pictures, okay? Go to the next, I think it's more. So you can see this one. Is this hand straight? Or there are some subluxation? You can see some subluxation along the metacarpophalangeal joint, okay? Now move to the next. I think it's more clear again. Okay, you can see something like swelling. So this one is not, but they can have something like, look like nodules, okay? If you look at the proximal interphalangeal joint, okay? You can see like a swollen, something that looks like nodules, especially on the second finger. Next slide. If you see this sign in exam, think of, okay, this is very typical. So who can tell us what about this? What is this deformity? For picture test, please.
Swan neck deformity.
Yeah, swan neck appearance, okay, swan neck deformity. So they can ask you some question about that. Okay, next slide. What of this one?
Spontaneous deformity.
10 years deformity, okay? Yes, next slide. So they could have a lot of deformities. The two commonest for the exams is this one and the Botanians and the Schwann neck. If they was going to bring hand for picture test or whatever, these two are the ones they will give, okay? But the first one, again, you should look into. If you see that hand, you think of rheumatoid arthritis. Next slide. So they could affect the foot, presenting with a lot of deformities. Valgus, clawing of the toes, callosities, a lot of them. I've not seen them actually, most of them, okay? But they could present with that. Next slide. You can see this, the foot are deformed. You can see the first finger. You understand? So this is deformed foot with some slight arcing, high arcing of the foot. If you look at it, okay? They hardly bring legs for the exams because hands are more commonly affected. And those Schwann neck and Botanians, they're the commonest ones for the exams. Next slide. You can see again another deformity. This one, is it valgus or varus? Okay, next slide.
Varus. Varus.
Okay, next slide. You can see another deformed, which like look what appears like a nodule on that big toe. These are also trying to show like Schwann neck again appearing in the legs, in the toes. Okay, next slide. So they could come with a lot of symptoms. Will be constitutional symptoms like low-grade fever, fatigue, lethargy, weakness, and stiffness. Again, they could come down with features of complications of the system affected. Next slide. What are the extra-articular manifestations? They can affect skin, eyes, heart, lungs, neurology, hematology, reticular endothelial system, Felty syndrome, if they have neutropenia, and if they develop splenomegaly, neutropenia, and rheumatoid arthritis. That is a triad. For the exam, the following are component of Felty syndrome except neutropenia. Some people say leukopenia. You understand? Yes, splenomegaly, yes, rheumatoid arthritis. So these are the triad of Felty syndrome. Next slide. You can see the chest X-ray of a patient with rheumatoid arthritis. They could develop more than 10 deformities in the one. They could have lung fibrosis, especially in the lower lung. Okay, lower lung fibrosis is one of the causes of lower lung fibrosis. 2, they could develop pleural effusion, exudative pleural effusion. Yesterday we mentioned causes of pleural effusion. 3, they could develop lung collapse. 4, they could develop bronchiectasis from the lung. Okay. 5, they could develop cavitation in the lungs. 6, they could develop some nodules, rheumatoid nodules. They could also be seen in the lungs. Okay. Now, these are some of they could develop some interstitial pneumonias in the lungs. So the lungs is one of the commonest symptoms affected. If you're evaluating patient with rheumatoid arthritis, you have to do X-ray, chest X-ray, even if he doesn't have any features of the lung affectation. Next slide. So skin, you can see these are the disease affected. These are the skin, some of the skin manifestations. Next slide. So you can see a clear picture of nodules, rheumatoid nodules. They develop commonly in the extensor surfaces. Okay, some of them are mildly tender. Next slide. So you can see how the hand, this one is it clawing or something of the hand, Abi? Okay. So they could have deformities, like clawing of the toes of the hand. Okay. Next slide. They could develop some vasculitis leading to this kind of ulcers because of the vasculitis. Okay. So these are all complications of the disease. Next slide. You can see they develop gangrene, all because of vasculitis. So vasculitis is very common. It's one of the diseases that can cause stroke because of vasculitis, inflammation of the vessels, okay? So they can obstruct the blood flow to certain parts of the body. So this one, gangrene. So next slide. Eyes, you can see all the other features they can develop from the eye. Keratoconjunctiva sicca, episcleritis, scleritis. So if you're examining a patient with rheumatoid, you have to examine the eye. You have to do eye examination thoroughly. You have to use your fundoscopy, okay? Apart from the visible inspection of the eye. Next slide. You can see some of those deformities mentioned. Next. Another one, all those episcleritis. So what are the factors associated with poor prognosis? If you develop RA at early age, for those that have positive rheumatoid factor, that's seropositive, if they have high titer of the disease, of the factor, if you have marked elevation of ESR and C-reactive protein, if the more than 20 swollen joints are affected, if you have early radiographic detection of erosion, we say it's an erosive disease. If you have severe functional disability at presentation, some genetic, there are some HLA, they are also involved, like DR3. If you have extra articular disease, we said it affects various organs in the body, skin, neural, CNS, lungs, heart. In the heart, they could cause cardiomyopathy, they could cause endocarditis, they could cause even myocarditis. They could even cause conduction block. Patient may present with arrhythmia because of rheumatoid arthritis. So they could cause anything in the heart. Again. Next slide. So these are some of the X-ray features of rheumatoid erosion. We say it's an erosive, so you can see is an important surrogate marker of arthritis. If they develop erosion, meaning it's an active, they used to call it, is it an active RA or non-active? So one of the marker that you know, this patient has an active RA. If he has deformity or he has some erosion in the X-ray, or he has involvement of extra articular sites, so that's qualified to be erosive, to be an active disease. Next slide. You can see this X-ray. Look at this first finger. You can see there is a bone erosion. There is some subluxation of. So you can see erosion. It's an erosive disease. You can see erosion at various points, especially at the first interphalangeal joints. You can see there are a lot of erosion. First, second, and third finger, they are erosive. Okay, so it's an erosive disease. Next. So how do you manage? Management will be divided into non-pharmacological, pharmacological, and surgery. For non-pharmacological, you have to educate the patient. This is a chronic illness. There is no cure for it, but If you are taking your medication, it will prevent you from having complications. And again, it will halt the progression of the disease. Sometimes you may need to do physiotherapy and even occupational therapy. Imagine somebody that is a typist in a ministry developing rheumatoid arthritis, an active one. So he cannot be able to perform the function he does. So education is very important, okay? And they need to adhere to this drug. Pharmacologically, yes, you can give drug to relieve the pain. You can give the drug to halt the progression of the disease or to even reverse the disease. You can give the drug to reduce inflammation. And there are neurotherapies that have shown to have certain benefits in the treatment of disease. Sometimes you need to do surgery, especially for the reformed one. And again, sometimes you need to treat the complication of the disease because they can develop a lot of disease we mentioned above. Next slide. Next. Next. So it's a multidisciplinary. You can see the graph before. It's involving all the disciplines: nurses, psychiatrists, physiotherapists, rheumatologists, anybody. So these are the goals of the treatment. Next slide. Pharmacological use NSAIDs, especially if there is no, okay, you can use DMARDs. You can also use steroid, okay? Details of how they are used is in the next slide, please. Let's go to the next slide. So these are the DMARDs. They can come out in exam. The following are disease-modifying anti-rheumatic drugs. Hydroxychloroquine is one of the common drugs that reverses some of those joint affectation. Sulfasalazine, methotrexate, TNF-alpha antagonist, leflunomide, interleukin-1. And there are newer agents like rituximab, anti-CD20, tocilizumab, abatacept, and tofacitinib. There is interleukin-1 antagonist like anakinra, which could be used for both gouty arthritis and rheumatoid arthritis. Okay, so these are the demands. Their details is, I think, in the subsequent lectures. I'm sorry, slide. Next slide. Next slides. Next. We'll explain this one next. Okay, what are the prognoses? I'll explain those ones. RA can shorten the lifespan for 3 to 18 years. Most of the patients die from the cardiovascular disease, infection, or lympho. RA is a risk factor for lymphoproliferative disease like lymphomas, okay? So you have a patient with rheumatoid, you have to look for the presence of those diseases. Overall, rheumatoid arthritis patients are much better than at any other time in the history due to ongoing research and movement. Okay, do we have a next slide so that I'll explain the other one? These are the consequences of rheumatoid arthritis: premature mortality, increased morbidity, significant impact on quality of life, work disability. Okay, next slide. So in conclusion, okay, before we conclude, those better slide is just the guideline on how to use the drug. If somebody comes with the disease today, rheumatoid arthritis, there are 2-3 drugs that you must start with. One, you have to give him hydroxychloroquine, number one. Number two, you have to give steroid, even if it is in low dose. Number three, you have to give plus or minus among one of those demands. But sulfasalazine is one of the drugs preferred. But these three drugs you have to give. If there is pain, severe pain, swelling, you have to give analgesic. But you have to give hydroxychloroquine, you have to give steroid, plus or minus analgesic, plus or minus some of those demands. But some people prefer to give demand when there are deformity because most of them are not available and some of them are expensive. But some studies have shown that starting demands earlier helps in reversing or altering the progression of the disease. So in conclusion, rheumatoid arthritis is a chronic multisystemic progressive disease that severely impacts quality of life and life expectancy. It leads to substantial direct and indirect costs, and more than 50% of the costs are utilized by less than 10% of the patient. Successful treatment can reduce mortality. Okay, do we have any slides? So, my people, this is rheumatoid arthritis. Please bear with me. We have to be a bit faster, cover within time, and I'm presently somewhere. I don't have much church. So tomorrow, by God's grace, we take 2 or 3 again. Your exam is coming. The advice I want to give you is, please, this is the time that you maximize your time. It's not the time to be on your phone every day. It's the time to study, look at the past questions, discuss with your colleagues. Every day, examine 3 or 5 systems. Today, okay, low motor system of the lower limb, abdomen, chest, general physical, jugular venous pressure. Tomorrow, pulses, you have to, so that after every 2 days, you must have exhausted all the systems. If you used to that, that means every 2 days you examine all the systems, either supervised or unsupervised. You understand? Then for communication, please, wherever you get 1, 2, 3 people, practice. History, ethics. Okay, let's assume a 30-year-old comes to the history of cough. Take the history. So you understand, you practice. And I want to urge us that, please, we should also get previous question, even without previous question. Look at, I discuss with some people that have gone for this exam. What are the natures of, you understand, so that you align yourself. I believe we can have some previous questions. And look at these lectures again that we've been, pick 2, 3 important things on each lectures and learn. These are the things that are going to come out in exam. Most of the questions are something that use your previous knowledge, okay? However, if there is a question that has been coming that is not clarified, you look for. Ask us. If we know, we tell you. Most of us have experience. We are opportune to be examiners the last 4 years during their exams. For those that are doing their own encounter, we discuss physically on some of the lapses we notice and how to improve. I believe my Oga there, Dr. Bashir, will also give you some guide. But the most important thing is we should utilize this time very well. You understand, your exam is around the corner. Please read as much as you can, discuss as much as you can. If you have any question, you let us. Practice those clinicals, because clinical is very, very important in any exam in Nigeria. It's given the most priority in most of the cases, okay? So if you have any question, clarification, you ask. If they're going to ask you picture test on rheumatoid, likely those hands, Schwann neck, and Botanius deformity, okay? However, all those pictures we should put in our mind, okay? So any question?
Just clarification for me, actually. You said for gout, the most common joint affected is the first metacarpophalangeal joint, right?
I said, first joint of the first digit, the toe.
Okay.
Metatarsophalangeal joint, first met of the big toe.
Okay. And then for psoriasis is the, which one?
Is the distal interphalangeal joint. Is the commonest joint affected.
Okay, thank you.
Yeah. So if they give you scenario, they say metacarpophalangeal or metatarsophalangeal joint is affected. Just look at if there is 1 or 2 things suggested of RA. This also signifies this is most likely to be RA. They give you scenario, you don't know what, but they mention distal interphalangeal joint. Most likely psoriatic arthritis. If they say they saw X-ray, there are erosion, what have you? The X-ray of the joint affected, there are erosion. You think of rheumatoid arthritis more than the osteoarthritis. You understand? If they give you scenario, the commonest joint affected by gouty arthritis is first of the metatarsophalangeal joint of the big toe, meaning the big toe is affected more than any other joint in the body. You understand? All right, thank you. Thank you. If you have any question, please ask. If I'm not a rheumatologist, okay? Please bear with me. If I know, I can tell you. If I don't know, I'll tell you. But I'm opportune to live with rheumatologists in my hospital. It's not everybody have that opportunity. We have a professor, and we have 2, 3 consultants in rheumatology. So if there is anything that you ask me, I can't answer, I can contact them and also tell us subsequent meeting. Okay. The essence is to pass good information. Okay.
Most popular question asked between this rheumatoid arthritis. What's the main difference between osteoarthritis and rheumatoid arthritis?
Okay, there are more than 20, 50 differences between osteoarthritis and rheumatoid. One, the age. Age affected by rheumatoid arthritis is usually the younger age. It's seen in people of 20, 30, 40, commonly. While osteoarthritis, 50, 60, 70, 80, 90. So the age. Are we together?
Yes, sir.
Two, the joint affected. Rheumatoid arthritis, we said smaller joints, right? Of either the hand or the legs, you understand? So osteoarthritis affect larger joint, knees, hip. You understand? You
Okay.
understand? Knee and hip are the common or some of the commonest joint affected. However, they could also affect other joints, but knees and so just bearing joints, joint, you understand? Joint that bear the weight. So based on the joint affected. It's more common. Osteoarthritis is more common, rheumatoid arthritis is more common in females.
Okay.
Even osteoarthritis to some extent, there are slight preponderance in females. You understand?
Okay.
There are certain HLAs that are associated with rheumatoid arthritis, like D3. I'm not sure of DR2. You understand? So the HLAs for osteoarthritis, again, they differ. So even the genetic thing. And obesity is a very good risk factor for osteoarthritis, but it's not any risk factor for RA. Okay?
Okay.
RA is an erosive disease. Rheumatoid is an erosive disease, while osteoarthritis is a degenerative disease.
Okay.
Yeah.
Okay. Thank you very much.
No problem. Thank you. Thank you. Thank you. Thank you. So any other question, please? All right. In the absence of question, I wish you best. I wish the lecture will be very important for us for practice and for the exams. So we meet tomorrow, same time. Thank you. Thank you very much. Thank Met Tutors for giving us this opportunity. All right. Bye-bye. Thank you.
Thank you, sir.
Welcome. Welcome.